Welcome back to Studious. Today we are tackling one of the most important, most prevalent, and most frequently examined diseases in all of medicine, chronic obstructive pulmonary disease, or COPD. According to the World Health Organization, COPD is the third leading cause of death globally, responsible for over 3 million deaths every year. Despite its prevalence, it is consistently underdiagnosed and undertreated because its progression is insidious, its symptoms are often normalized, and by the time many patients seek care, significant and irreversible damage has already been done. This video is a complete standalone clinical blueprint built around the latest GOLD guidelines, the Global Initiative for Chronic Obstructive Lung Disease, which represents the international gold standard for COPD management. We will cover the pathophysiology from the airway level, both disease phenotypes, the genetic and environmental causes, clinical presentation, diagnostic spirometry, GOLD severity grading, the full treatment matrix, oxygen therapy, comprehensive management beyond inhalers, and the serious cardiovascular complications of untreated disease. Let's build the full picture from the ground up.
The single most important concept that separates COPD from every other obstructive lung disease, and particularly from asthma, is the word irreversible. To understand this, compare the three airway states side by side. In a normal airway, the lumen is open and clear, alveoli are intact, and gas exchange is efficient and unrestricted. In asthma, the obstruction is functional, caused by smooth muscle spasm, mucosal swelling, and mucus plugging, all of which are reversible with bronchodilators and anti-inflammatory therapy. The airway wall structure itself remains anatomically intact. In COPD, the situation is entirely different and fundamentally more serious. The obstruction is caused by permanent physical destruction of the airway and lung parenchyma. The actual tissue architecture has been dismantled. Alveolar walls are destroyed, elastic tissue is gone, and small airway walls are permanently thickened and scarred. No bronchodilator can rebuild destroyed tissue. No corticosteroid can restore lost alveoli. This is the critical clinical bottom line of COPD. Unlike asthma, this is a permanent baseline disease driven by irreversible parenchymal and airway destruction. All management from this point forward is about slowing progression and managing symptoms, not reversing what is already lost.
COPD is not a single uniform disease. It is an umbrella term covering two distinct pathological phenotypes that frequently coexist in the same patient. Understanding them separately is essential because they involve different anatomical sites, different mechanisms, and produce different diagnostic findings. The first phenotype is chronic bronchitis. The formal clinical definition is a productive cough occurring for at least 3 months per year for 2 consecutive years. The primary site of damage is the bronchi and bronchioles, the conducting airways. The mechanism is mucus gland hypertrophy. The mucus glands enlarge and hypersecrete, physically plugging the conducting tubes with thick, purulent mucus. Critically, in pure chronic bronchitis, the alveoli remain structurally intact. This is why the DLCO test, the diffusion capacity of carbon monoxide, is normal. Gas exchange surface area is preserved. The second phenotype is emphysema. Here, the primary site is the alveoli themselves. Parenchymal tissue destruction causes permanent dilation of air spaces distal to the terminal bronchioles, and the loss of elastic recoil means airways collapse on exhalation. The alveolar walls are destroyed, which is why the DLCO is reduced. There's less surface area for gas exchange. In clinical practice, most patients have both phenotypes simultaneously.
Understanding what causes COPD is essential, not just for prevention, but because the cause shapes both the pathological pattern and your screening decisions. Approximately 90% of COPD cases are driven by exogenous, external exposures. The dominant cause is tobacco smoke. Chronic inhalation over 20 or more years generates sustained oxidative stress and inflammatory injury to the bronchial mucosa and alveolar parenchyma. In the developing world, indoor burning of biomass fuels, wood, dung, agricultural waste, is equally significant, representing the primary cause in non-smoking populations in low-income countries. Occupational dust exposure, particularly silica in mining and coal dust in coal workers, is the third major exogenous trigger. But here is where your clinical thinking must expand. A young patient or a non-smoker presenting with COPD is a red flag that demands targeted genetic screening. The culprit is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is a protective serine protease inhibitor that normally blocks elastase, an enzyme that continuously degrades connective tissue. Without that shield, elastase destroys lung parenchyma unchecked, producing pan-acinar emphysema, affecting the entire bronchiole and alveolus, predominantly in the lower lobes. Smoking-related emphysema, by contrast, produces centriacinar destruction, targeting the respiratory bronchiole. This pathological pattern distinction is a high-yield examination point,
Before we discuss how to diagnose COPD with tests, you need to be able to recognize it at the bedside, because the clinical examination of a COPD patient contains findings that are not random signs, but deliberate biomechanical adaptations the body develops to cope with progressive airflow obstruction. The first and most visually striking adaptation is the tripod position. The patient leans forward, placing both hands on their knees or on the edge of a surface. This is not a behavioral quirk, it is a mechanical strategy. By fixing the shoulder girdle and leaning forward, the patient optimizes the mechanical advantage of their accessory respiratory muscles, the sternocleidomastoid, scalenes, and intercostals, enabling them to generate more expiratory force to push air out of their hyperinflated, barrel-shaped lungs. The second hallmark presentation is chronic dyspnea that has progressed from exertional, initially only with activity, to resting dyspnea in advanced disease, accompanied by daily productive cough with mouthfuls of purulent sputum. The third adaptation, and one of the most elegant pieces of respiratory physiology, is pursed lip breathing. By creating resistance at the lips during exhalation, the patient generates a back pressure, a form of positive end expiratory pressure that keeps the destroyed floppy alveoli distended throughout the expiratory phase, preventing their premature collapse and buying time for air to escape.
Clinical suspicion alone is insufficient to diagnose COPD. The diagnosis requires objective confirmation, and that confirmation comes exclusively from spirometry. Here is the diagnostic algorithm. The patient forcefully exhales into a spirometer. The device measures FEV1, the forced expiratory volume in 1 second, and FVC, the forced vital capacity, the total volume exhaled. The critical ratio is FEV1 divided by FVC. Per GOLD guidelines, a post-bronchodilator FEV1 to FVC ratio of less than 70% is the mandatory diagnostic threshold for COPD, and it confirms irreversible airflow obstruction. If the ratio is at or above 70%, COPD is excluded. Look for an alternative diagnosis. Once irreversible obstruction is confirmed by the ratio, you then perform a DLCO test, the diffusion capacity of carbon monoxide, to differentiate between the two phenotypes. If DLCO is normal, the gas exchange surface is intact, pointing toward chronic bronchitis as the dominant phenotype. If DLCO is reduced, gas exchange surface has been destroyed, confirming the emphysema phenotype. One absolute rule: normal spirometry entirely rules out COPD. You cannot have COPD with a normal FEV1 to FVC ratio. This is a non-negotiable diagnostic standard across all international guidelines.
Beyond spirometry, 3 supporting diagnostic modalities provide critical information about the structural extent of disease and the body's systemic adaptations to chronic oxygen deprivation. First, imaging. On chest X-ray, the COPD patient displays a highly characteristic constellation of findings: hyperinflated lungs with flattened diaphragms because chronically trapped air pushes the diaphragm down, a barrel-shaped chest with increased anterior-posterior diameter, and a tubular, hanging heart that appears narrow and vertically elongated because the hyperinflated lungs compress it on both sides. On CT scan, emphysematous bullae, large air-filled spaces formed by destroyed and confluent alveoli, are directly visible. Second, hematology. Chronic hypoxia triggers a predictable compensatory feedback loop. The kidneys and adrenal glands detect persistently low oxygen and secrete erythropoietin. EPO stimulates the bone marrow to produce more red blood cells, raising the hematocrit, a condition called secondary polycythemia. This is a reliable indirect marker of chronic hypoxemia severity. Third, arterial blood gases. ABGs are not performed routinely. They are indicated specifically when oxygen saturation drops below 92%, when altered mental status is present, or during an acute exacerbation. Situations where knowing the exact carbon dioxide level and acid-base status critically guides management.
Once COPD is diagnosed spirometrically, you classify the severity of airflow limitation using the GOLD grading system, which runs from GOLD 1 through GOLD 4. This classification is based entirely on the FEV1 as a percentage of the predicted value for that patient's age, sex, and height. Here is the critical memory tool, the deduct 30 rule. The thresholds descend in intervals of 30 percentage points, making them easy to memorize. GOLD 1, mild COPD, is an FEV1 greater than 80% of predicted. Airflow limitation is present on spirometry, but symptoms may be minimal or absent. GOLD 2, moderate COPD, FEV1 falls between 50 and 80%. Exertional dyspnea typically becomes apparent at this stage, and many patients first seek medical attention here. GOLD 3, severe COPD, FEV1 drops to between 30 and 50% of predicted. Symptoms are significantly limiting, exacerbations become more frequent, and quality of life is markedly impaired. GOLD 4, very severe COPD, FEV1 falls below 30% of predicted. This represents end-stage disease with chronic respiratory failure, and it carries the highest mortality. The key clinical bottom line, the GOLD 1 to 4 classification strictly measures the mechanical severity of airflow limitation via FEV1. It does not, by itself, determine treatment. For that, you need the second dimension, symptom burden and exacerbation risk.
The GOLD spirometric grades alone do not determine treatment. GOLD guidelines recognize that two patients with identical FEV1 values can have dramatically different daily symptom experiences and exacerbation histories, and their treatment must reflect that difference. This is why the comprehensive GOLD classification adds a second axis, symptom burden and exacerbation risk, producing the ABCD treatment groups. The horizontal axis measures symptom burden, quantified using the MMRC dyspnea scale or the CAT, COPD assessment test score. Mild symptoms score MMRC 0 to 1 or CAT below 10. Severe symptoms score MMRC 2 or above or CAT at or above 10. The vertical axis measures exacerbation risk. Low risk means 0 or 1 exacerbation per year with no hospitalizations. High risk means 2 or more exacerbations per year, or at least 1 exacerbation requiring hospitalization. Plotting these two axes produces 4 quadrants. Group A, low risk, mild symptoms. Group B, low risk, severe symptoms. Group C, high risk, mild symptoms. Group D, high risk, severe symptoms, the most complex and dangerous patient group. This A to D classification is what drives the treatment algorithm. It prioritizes the patient's daily lived experience and their hospital risk over raw spirometry numbers alone, a fundamentally patient-centered approach.
Now that you can classify any COPD patient into a group, the pharmacological treatment algorithm maps directly onto that classification in a logical, stepwise fashion. Group A patients, low risk, mild symptoms, receive either a short-acting beta agonist or a short-acting muscarinic antagonist on an as-needed basis for breakthrough symptoms, or a long-acting beta agonist for more regular control. The goal is symptom relief with minimal pharmacological burden. Group B patients, low risk but with severe daily symptoms, are stepped up to either a long-acting beta agonist or a long-acting muscarinic antagonist as a daily maintenance controller. Both are appropriate. Clinical choice depends on patient profile and tolerability.
Group C patients, high exacerbation risk despite mild symptoms, receive a LAMA as the preferred first choice because evidence shows LAMAs are superior to LAMAs in preventing exacerbations over the longer term. Group D patients, the highest risk group with both frequent exacerbations and severe daily symptoms, require maximum combination therapy, a LAMA plus a LABA plus an inhaled corticosteroid as triple therapy. Additionally, in selected Group D patients with a history of frequent bacterial exacerbations, a maintenance macrolide antibiotic, such as azithromycin, may be added to reduce exacerbation frequency by suppressing bacterial colonization of the chronically inflamed airways Of all the management principles in COPD, none is more dangerous to misunderstand than supplemental oxygen. In a healthy person, the primary stimulus to breathe is rising carbon dioxide, the hypercapnic drive. However, in chronic severe COPD patients who have lived with persistently elevated CO2 for years, the brain gradually adapts and reduces its sensitivity to high CO2. Their primary remaining drive to breathe shifts to the hypoxic drive. They breathe because their oxygen is low. When you administer high-concentration oxygen to such a patient and their oxygen saturation rises toward 100%, you eliminate that hypoxic stimulus. Their respiratory drive falls, breathing slows and becomes shallow, and CO2 accumulates rapidly, producing life-threatening hypercapnia. This is the oxygen paradox in COPD. The correct target saturation for any COPD patient receiving supplemental oxygen is 90 to 93%. Not 94 to 98%, as in most other conditions, because that narrow window maintains just enough hypoxic drive to keep the patient breathing adequately. When oxygen saturation chronically falls below 88% at rest, long-term oxygen therapy, LTOT, via home oxygen cylinders is indicated. And this is critically important. LTOT is one of the only interventions proven to extend life in severe COPD. Along with smoking cessation, it is one of just 2 evidence-based treatments that actually alter the mortality trajectory.
Inhalers are the foundation of COPD pharmacotherapy, but genuinely comprehensive COPD management requires 4 additional pillars that address the disease from angles that bronchodilators alone cannot. First, pharmacological adjuncts. Mucolytics, particularly N-acetylcysteine, help break down and thin the thick, tenacious mucus that chronically plugs the conducting airways in bronchitis patients, making it easier to expectorate. Theophylline, a methylxanthine bronchodilator, can be added in refractory cases, but carries a significant arrhythmia risk and a narrow therapeutic window, so it is reserved as a last resort. Second, vaccinations. Annual influenza vaccination and pneumococcal polysaccharide vaccination, mandatory for patients over 65, are essential protective measures because respiratory infections are the most common triggers of acute exacerbations, and each exacerbation accelerates the overall decline in lung function. Third, physiotherapy. Chest physiotherapy with postural drainage techniques helps mechanically clear chronic mucus plugging from the conducting airways, improving airflow and reducing the frequency of infective exacerbations. Fourth, surgical options. In selected patients, lung volume reduction surgery can improve mechanics by removing hyperinflated, non-functional lung tissue. Bulectomy removes large, ruptured, air-filled blebs, and for end-stage disease with catastrophic destruction, lung transplantation remains the final option. Anchoring all of this, smoking cessation is the single most important intervention in all of COPD management.
We close with the most serious and sobering dimension of COPD. What happens when the disease is left inadequately treated and allowed to progress to its end stage? The path from lung destruction to cardiovascular death follows a predictable, mechanistically coherent cascade. It begins with end-stage parenchymal destruction, massive loss of alveoli and airway walls, combined with the constant risk of Boulez rupture causing spontaneous pneumothorax. Persistent and severe airflow obstruction generates chronic respiratory failure. Sustained hypoxia alters systemic vascular resistance throughout the body. The pulmonary circulation responds to chronic low oxygen levels by reflexively constricting the pulmonary arteries, a mechanism called hypoxic pulmonary vasoconstriction. This is the body's attempt to redirect blood away from poorly ventilated lung segments. But in COPD, where almost all lung tissue is affected, the vasoconstriction becomes generalized, producing pulmonary hypertension. The right ventricle, which must pump blood through those constricted pulmonary arteries, now faces massively elevated resistance. It hypertrophies under the strain, dilates, and eventually fails, a condition called cor pulmonale, right-sided heart failure driven entirely by the initial pulmonary disease. The clinical bottom line: COPD is ultimately a cardiopulmonary disease. Untreated parenchymal destruction inevitably leads to right heart failure. Thank you for watching Studious. Please like, comment, share, and subscribe for more high-yield clinical content.